Well, thank you very much for that warm welcome, and I want to thank the American Behçhet Association, of course, obviously the Vasculitis Foundation and Celgene for allowing me to speak to you. It's a singular privilege to be up here and talk to you because I do treat Behçet's patients, but I find them the most educated and, of course, obviously the most grateful if our therapies work. Again, it's wonderful to take care of these patients. So, again, I thank you and welcome to Atlanta. So the topic is the understanding Behçet's disease, and my background is a rheumatologist. I've been practicing for 31 years, and so eventually you get to see patients, and I realized that as I'm treating this disease, it is one of the most singularly I would say a disease that we see that is very, very specific to patients. It's not the typical type of disease that we see in a rheumatic practice. So bear in mind when we talk about this and we go into discussions about Behçet's disease, that your disease is unique to you. And again, you shouldn't always just extrapolate with some of the data that I'm going to show you today in the post session. So if you look at the summit, it's hosted by the American Behçet's Disease and the Vasculitis Foundation, and it's with sponsorship from Celgene. I'm speaking on behalf of these organizations. The information presented is subject to specific rules and regulations in the U.S. and therefore is intended for U.S. audiences. So let's talk a little bit about the title here. It says Behçet's disease is a chronic inflammatory disease. So notice there's two words there, chronic and inflammatory. So inflammation is not necessarily a bad thing, all right? We need it to protect ourselves. It's a defensive mechanism, it defends against infection. It also helps us to heal wounds. But inflammation usually stops. When the agent is gone or if the wound is healed, it stops. Chronic inflammation does not. And so when we talk about Behçet's disease, it's a chronic inflammation of various different structures in your body that does not stop. It may go away for some time, but then it comes back. So that's the main feature about when we talk about chronic inflammation. The second thing, one of the main factors of Behçet's disease that's common in almost all patients is mouth ulcers. So that's almost 100% of patients will have mouth ulcers. If you look at where the genesis of Behçet's disease, and we look at where it's more common, if we look at, I come from Michigan, and I did my undergraduate at the University of Michigan, so if you go to Michigan Stadium, it's roughly about 100,000. They always add on more seats, it always gets crammed year after year, but it's about 100,000 people at a football stadium at one time. So I can imagine that in that stadium, if you have 100,000, if you're in the United States, 5 of those people in that stadium could have Behçet's disease. Now, if you go to Turkey, which is that big kind of orange kind of dot there in the middle of Europe there, you see if you were in a soccer stadium there and there was 100,000, there are about 400 patients with Behçet's disease. So if you look at it, depending upon what region of the country at or the world, you're going to see the differences in terms of Behçet's, in terms of the numbers. So that's why the clinicians here in the United States are not as in tune as diagnosing Behçet's disease as we probably would see somewhere if you were practicing in Turkey. Also notice you can almost draw a line straight across what we call the Silk Road. Now the Silk Road really was an ancient travel. It was basically routes for commerce between Europe and Far East and Asia. That Silk Road was really for commerce for, let's say, like silk, or it was for religious purposes they would travel, or it was also with disease. And so it seems to be along that pathway we see focal areas of where you see groups of patients with Behçet's disease. So that's why they call it the disease of the Silk Road. If you look at the typical age, and again, I don't like to use the word typical with Behçet's, but typical age is between 20 and 40 years of age. So that's where we usually would see patients that first present, but you could see probably patients on the other side of the spectrum as well. So when a patient comes to me, if I'm able to make a diagnosis of Behçet's, sometimes it's challenging, they say, how did I get this? What did I do? And one thing about rheumatology is what we do is most of our diseases are not caused by something that you do. It's not your fault. It's possibly something in the environment, and there's a lot of speculation of what that is. If we go back over the Silk Road, we think possibly it's related to infection, but then you couple it with potential with gene. You may be genetically susceptible. Now, some people confuse that with heredity. So you may have the genes in your family, but they may not express themselves, and if you weren't exposed to something in the environment, you may not get Behçet's disease. So people are confused sometimes, say, well, none of my family has Behçet's. You may have the genes, but you may not express the disease. So you have a combination of both the environmental trigger, something in the genes, and then you have what they call an immune response. This is the same response I talked to you about earlier when we fight off infections or we have issues with healing of our wounds. But in this case, it's a maladaptive type of response. It becomes targeted to other cells that are not really injured or infected. And so the way it does that, it does by, say, increased production of pro-inflammatory cytokines. What those words mean, their cytokines are chemical messengers. They're like cell phones that you were supposed to silence, right? They're supposed to have cell phones. They're like, they communicate from cell to cell to tell where the cells are supposed to go and where they're not supposed to be. So you have this production of these, what they call cytokines, which then upregulate your immune system and then develop inflammation, which remains chronic in some cases, and that's where the destruction comes in the pathology. Here we talk about Behçet's. Now, in this slide, it kind of shows you what the spectrum is, okay? And when I talk about spectrum, I'm talking about not all patients are going to manifest this. So if you look at it, oral ulcers, 100%. I mean, I've not seen a Behçet's patient that didn't have oral ulcers. But if you look underneath, then they're genital ulcers. So about 70 to 90% of the patients will develop genital ulcers. The tricky part is with Behçet's, sometimes the genital ulcers come before the oral ulcers. And so it can be even more difficult to challenge. You imagine when you're seeing a specialist for the first time and you get your first ulcer. Then you have skin lesions. Skin lesions can be very subtle. It can present as an acne-like presentation, or what we call sometimes folliculitis, which is a hair follicle that gets inflamed. Or it can present a condition called erythema nodosum, which is our painful lesions in the lower extremities. Or it can present as a superficial phlebitis. So it has a myriad of skin presentations, and some of them may be dismissed as being just ordinary acne. So again, it takes a clue to figure out you're getting ulcers and acne. Maybe there's something else going on. Then you have, of course, ocular involvement. This is one of the things that we watch for because these are one of the complications of Behçet's that we really need to treat urgently. And with the eye disease of Behçet's disease, it comes in a spectrum as well. It can present as inflammation of the eye, the covering of the eye, we call scleritis. It can also present of the uveal tract, which is basically the tunnel that goes from the front of the eye to the back. And it can also present in the back of the eye, which can be which is urgent. We need to treat that, and you may not have symptoms early on. And so that's why you'll be seeing an ophthalmologist. If you have Behçet's disease, one of the people that you're going to be seeing is an ophthalmologist. Then there's joint involvement. Because we're rheumatologists, we treat joints. Patients do have joint disease, and it comes from a whole spectrum again. I see patients with joint pain, and I have patients with what we call arthritis, where the joints are actually swollen. Fortunately, it's not deforming, but it's painful. So again, it's not like we see with rheumatoid and other diseases, but it gives us a clue as to if we have someone with joint disease and the skin disease and the mouth ulcers, we begin to make a pattern like a puzzle to say, this may be Behçet's disease. The vascular involvement is fairly rare, especially in this country, but it does occur. This is called vasculitis. It's inflammation of the arteries. It can cause inflammation and damage to organs, or it causes inflammation in the veins and cause blood clots. So this is one of the complications. So I ask patients, don't go on the internet, and of course they do. And that's what you see, right? So that's what you look at, and then they will look at the most horrible cases of Behçet. That doesn't necessarily apply to you, okay? Because I don't usually see that as often as I did, and we're seeing a different kind of Behçet, we can talk about later. Neurological involvement. This is again a tricky part because this sometimes involves the isolated part in the brain, and it can present as a vasculitis, or it can present in clots, or I'm seeing more often, it presents a whole host of other things like fatigue. It can present as depression and other things as well that we're beginning to understand inflammation in a whole different way. So the neurological involvement of Behçet's disease is fortunately fairly rare, but it can be something that needs, again, urgent treatment when it occurs. And finally, there's gastrointestinal involvement. This is tricky as well because what happens is the gastrointestinal involvement of Behçet's sometimes is misdiagnosed as Crohn's disease. And so as a result, if you have a gastroenterologist and you do present with inflammation of your colon, sometimes it's tricky to differentiate the two. So you need a specialist that kind of knows about Behçet's disease. Am I dealing with Crohn's disease with mouth ulcers, or am I dealing with Behçet's disease with inflammation of the gut? So again, that's another thing that we need to be mindful of and tell our patients. The good news is that most of the time with Behçet's patients is when they get the disease and they've had it for a long period of time, let's say 5 to 10 years, it's unlikely they're going to develop some of these associated symptoms. There's always the exception to the rule, but I find my patients, the longer I treat them, the longer I follow them, the more reassured it is that they're not going to develop such complications. So how do you diagnose it? So if you go to a doctor's office and you get a blood pressure, that's easy. You get a blood pressure cuff, your blood pressure's up. You go and see a doctor for diabetes. Behçet's not like that. We don't have a blood test for Behçet's. That's number one. So you can't just go in and say, can I get a blood tested for this disease? Number two, this is the ISG criteria, the International Study Group. It was formed in 1990. So we're using almost 20-year-old criteria, and these were mostly designed to put people in clinical studies, but nevertheless, it's a guide that we use to make the diagnosis. So you have to have the recurrent ulcers, the mouth ulcers, and you have to have at least 3 of these recurrences within 12 months. So we'd like to see the ulcers, examine them, and so forth. Most of these patients, by the time they see me, they've already had them. So that's the first thing, but you need 2 other criteria. And you see in the box there, all 4 of them, you have to have recurrent genital ulcers, Or you can have the skin lesions that we talked about, and then some of them can be very subtle. The eye lesions, so some of my ophthalmology referrals I get in our area that refers us, from the ophthalmology portion, because the eye doctor says, oh, you have this inflammation of your eye, and by the way, you have mouth ulcers, so they refer them right away to us. And then there's the thing called positive pathergy. Now, pathergy is something that is not well understood, but the phenomenon is if you poke yourself with a needle, I suggest you do not do this at home. This is one of these things where you don't go on YouTube and say, oh, that's how you do the pathergy test. No, but that's how I learned how to do the pathergy. I went on YouTube. So you basically, what you do is you go on and you take a specific gauge needle. We like to use a 21 gauge needle, and we like to inject into the skin. And then we circle and we do 3 sites. And in 24 or 40 hours, you'll have an area of redness right around where I injected the needle, and there'll be like a little pustule. That's called pathergy. Now, the tricky part is the pathergy test is much more positive in Turkey than is here in the United States. Probably about 15% of the population here has a positive pathergy test versus almost 50% what we'd see somewhere in Istanbul, Turkey. So it's not exactly a diagnostic test. Sometimes patients will tell me when they get their blood drawn, they'll get the pustule. So that's a hint for me that something's going on. So clearly that's not always the case in terms of diagnosis. So you see how if you're frustrated, if you have Behçet's disease and you're frustrated with this, you can see why. It's a very tricky diagnosis. It relies on clinical aspects, not on laboratory studies or x-rays and so forth. So that's really where the challenge is on diagnosis. The other challenge is this disease evolves. So what happens is the mouth ulcers can be present for many, many years. So you can imagine you're going to the doctor and you see these mouth ulcers. You may go to a dentist. You may see an oral surgeon. So patients are frustrated because they go around for years and years, sometimes up to 5 to 8 years before another manifestation occurs, and they say, aha, you have Behçet's disease. So again, that's and because we were not trained, and we only trained on the classic cases, and the classic cases we were the ones to see in Turkey. Again, we don't always think about the Behçet's patient. When I learned on my boards, it was a young male that comes from, let's say, Iran or from Turkey. But yet, what about the woman that's childbearing age, that's young, that presents with mouth ulcers? We never thought about them as Behçet's disease. So we're realizing that our whole thought process on making this diagnosis has changed. And so again, being aware of that, not to look at people as a cookbook medicine or not looking at it as a kind of classic case, that's where some of the confusion arises. So again, the delay in diagnosis is because the disease itself delays itself in terms of the mouth ulcers. So these are some of the mouth ulcers that we typically would see, all right? And they're not every patient has all these mouth ulcers, but the one you talked about, the major aphthous ulcers, these are the ones that are severe. They're usually 1 to 2 centimeters in diameter. They can be extremely painful, and these are the ones that cause scarring. So not all Behçet's patients have non-scarring ulcers. These are the ones I would see, in terms of looking at the examination. The minor one, the oral aphthous, the one in the middle, the minor type oral, those are the most common ones I see. They come in crops. They basically will occur, maybe 2 or 3 of them. They may last from about 7 to 14 days, and then they resolve. And finally, there's the herpetiform ulcerations, which I see those as well. And those patients, again, they look like basically herpes simplex. So you can see where misdiagnosis can occur. If you're only getting these ulcers, some of these patients are being treated repeatedly with antiviral therapies or steroid injections or whatever the case may be, looking at basically that these are just recurring mouth ulcers, but being aware that there are many different types of mouth ulcers in Behçet's disease. There's not just one type. So putting this all together and saying, okay, how do we make our decision treatments in terms of our patients? Because that's the question some patients have. How do I get treated for this disease? And it's complicated. It's not very straightforward. First, we have to think about what organ is involvement. In other words, are we dealing with mouth ulcers, with gastrointestinal disease? Am I dealing with predominantly skin disease? Am I dealing with something in the brain? Am I dealing with the eyes? All this has to be factored in when you make this decision, because we usually go for the most organ at risk, and we will use the more aggressive therapies in that situation. Or if you have mouth ulcers, we also think about the fact that we may start with something local, and then we may move on to something more aggressive as well, in that aspect of it too. Disease severity is very important for me because you can have mouth ulcers, and some people will say, well, it's just mouth ulcers. They don't understand Behçet's disease. It can be very, very painful, and some of my patients can't even speak properly when they do have these mouth ulcers. They can't even eat. So when you talk about disease severity, you may just have mouth ulcers and a little bit of skin disease and may have had a history of eye disease, but nevertheless, we need to treat you because the mouth ulcers are causing you the severity that's really causing you to have all the problems and activities of daily living. eating, socialization, and so forth, leading to depression and frustration and anxiety. So disease severity to me, even though it is a mouth ulcer, is very important for me to be able to treat, especially if it's interfering with your activities of daily living. Then there's disease progression. I don't have a crystal ball. People say, what's going to happen to me? I have a Behçet's disease, what's going to happen? I only say time is going to tell. We're going to need constant surveillance. You're going to probably see multiple specialists. They're sympathetic toward Behçet's disease. But understanding is when we make that diagnosis for the first 5 years, we're going to be following you to make sure it doesn't manifest anyplace else. So I think very importantly what we do is we like to be able to follow you, and then what I do is I keep an eye on you, at least when I see you for the first couple times. Then after a while, when I get to know you better and I have other subspecialists helping me, I can get a frank idea where this is going to go to. And the good news is the vast majority of patients do quite well. So again, but it's the monitoring part. It's the worst part is that when the patient disappears on me and then 2 years later they show up with something worse. So again, I think the important part is to kind of maintain and be followed. Then you talk about the patient type. Who are we treating? Okay, if I'm treating a young woman who's of childbearing age, I'm going to be thinking about different medications I'm going to be using strategy than I'm going to be using someone that may be my age, in their 60s, and treating them accordingly. So patient types also matter. It really depends on who I'm going to be treating. And then finally, patient preference. Okay, what kind of treatment are you going to put up with? Will you put up with topical agents if I prescribe them? Will you put up with pills? Will you put up injections or so forth? I think that's a really, very important part because you have to integrate that in your part of your life. See, part of this disease, it tends to wax and wane. And so when you have a waxing and waning disease, how do I know whether the disease is going away or it's related to your medication, or if it comes back, is it because you weren't taking your medication? So compliance is very, very important for us. So when we do start a therapy for you, it's very important, number one, that we find the right therapy for you, something that you're comfortable with, going over the risks and the benefits of that therapy, and then maintaining that therapy. Because I know in our society is nobody wants to be on medications. I get that. I understand that. On the other hand, maintaining that consistency is very important for us because that's how I'm going to know whether my therapy is also effective. Or versus not taking their medication. So compliance is a very big issue. And the problem with compliance is too as well is if you don't take your blood pressure medication, you check your blood pressure, it's elevated. If you don't take your blood sugar medication, your sugar is elevated. If you don't take your medications for your Behçet's, it may take a couple weeks and boom, you'll have a flare. So that's the mystery of this disease. So again, compliance is very, very important in terms of what we do in terms of our management of this disease.